Part 5 of Neuro Disorders will address meningitis. This one will be a little bit longer than the others because it's a fairly common disorder. We can do something about it, and it can have a bad outcome if we don't implement our assessments and interventions immediately. So the pathophysiology associated with meningitis is an inflammation of the meninges from some type of a pathogen that was able to cross through the membranes. Because of the glucose within the spinal fluid, bacteria can replicate very rapidly. This leads to an inflammatory response, swelling, and meningeal irritation, therefore the symptoms. This picture shows you where all the meninges are in the central nervous system. Why is meningitis so important? Because there can be long-lasting complications. We can have hearing loss that's permanent, visual impairment that's permanent, behavioral changes that may or may not be permanent. It depends on how astute we were in determining that this kid needs to be put in front of a physician immediately so that we can get diagnostics and treatment started. We can have lasting learning disabilities as well as significant developmental delay. And this is the worst part of it, is you can have a perfectly normal child. They acquire meningitis, and it was so devastating to the child that they've never recovered. Ultimately, we end up with a mental retardation. We can have some cerebral palsy that can be mild to extensive, permanent seizure disorders, maybe paralysis, and hopefully not, but possible is death. Meningitis is typically in our 5-year-olds and under, but that doesn't mean that a school age or an adolescent cannot get it. Kids who are in close contact with one another have an increased incidence. So your daycare facilities, schools, crowded living conditions, which can even be in apartment buildings, as well as the college dorms. The incidence has decreased dramatically after the Haemophilus influenza B vaccine was developed, and assuming that these kids are getting it, we don't get this meningitis. Our immunocompromised kids can also develop a protozoal type or a fungal type of meningitis. So the portal of entry into the meninges can be a vascular dissemination from something as simple as an otitis media, a sinus infection, pharyngitis, an upper respiratory infection that becomes complicated, and pneumonia. So the bacteria becomes systemic, where it used to be a localized infection. We can also have a direct invasion into the meninges from trauma, so head trauma, a lumbar puncture that wasn't done under sterile conditions, or when a VP shunt becomes infected. The bacterial pathogens in the 2-month to 2-year-old tend to be your H. flu, strep pneumo, and beta strep. And the beta strep is far more common in our neonates, which is why we screen for this during pregnancy. There can be E. coli, and that would be coming from a UTI that has gone systemic. Tuberculosis is sort of an outlier, so the doctors would have to be thinking that this kid is at risk. And then we can have our Neisseria meningitis, and we're going to talk about that towards the end of the lecture. Sometimes they just lump it into a category of viral meningitis. They haven't really determined what the virus is, but it's acting like, looks like, and it's not bacterial, so they're going to say it's viral. But the ones that they can identify will be your enteroviruses, and we're in enterovirus season right now, mumps, which we rarely see, varicella in the unimmunized, and then the herpes. And of all of these, your herpes viral meningitis is one of the worst. We can prevent meningitis by prompt recognition and treatment of otitis media. Same thing with pneumonias. We can also vaccinate. When children come in contact with somebody that may have had meningococcal meningitis, then we will give all the close contacts, so it's not just children, it'll be the adults. We're going to give them rifampin and or Cipro. Do remember that when we give rifampin, they have to take the 7-day course, and it stains urine, tears, and sweat. They have contact lenses in. It can also stain the contact lenses. So this is part of your parent-patient education to anticipate that they're going to see this and not to become alarmed. Your assessment of a child who may have meningitis will find that a neonate has poor muscle tone. So it's a floppy baby. They're not pulling themselves together like they like to be. And they have a poor suck. So the mom's saying, you know what, this kid just won't eat. They used to eat, and now it's very difficult to get the kid to suck. They are going to have hypothermia because neonates don't have the ability to mount a fever response. They can have apnea and bradycardic spells, and then you're going to feel that fontanelle and it's going to be tense. They may just have seizures, and that's what brought the kid in. If the child has hypotension, they're not doing well. We anticipate shock. They may develop DIC as a complication, and then we're going to lose this kid. So we want to find them more when they're at the poor muscle tone, poor feeding stage. Our infants will also be poor feeders, but they will have a fever. Depending on the type of meningitis they have, it can go anywhere from 101 to 104. This kid's going to be irritable, and then they're going to progress from a stage of lethargy to decreased level of consciousness. They may or may not have vomiting, and that'll depend on the degree of intracranial pressure increase that has been caused by the bacterial invasion. They may have a seizure. And then also, as the pressure rises within the cranium, then if their fontanelle is open, if their sutures are not quite fused, we're going to see that it's becoming tense and widened. When we look at children, they're going to be different because the cranium can't expand. So these kids are going to complain of a headache. They're going to be irritable. They don't like to be exposed to light, and sound can also irritate them. They're going to have the nuchal rigidity. So newborns don't necessarily have nuchal rigidity. Infants may or may not have nuchal rigidity, but your kids are going to. So we can have seizures, fever, vomiting. So we have the Koenig sign, Brzezinski sign. This is Koenig's. We raise the kid's leg, and they are going to be fighting you. You bring that kid's leg up, and what's happening is it's stretching the meninges, and it's stretching it from the spinal canal all the way up to the brain, and it causes a lot of pain, and the kid's going to say no. They're going to stop you. And then the Brzezinski's is the chin to chest sign. So when you go to move their head forward, and when do we need to do this? We're going to be bringing both their legs up and their chin to chest when we're trying to do an LP. And you can see why a child is going to be fighting you to do this because it's causing intense pain. Viral meningitis is typically less severe unless it's HSV. So that's the herpes simplex virus. They're going to have very similar signs: irritable, not feeding well, low-grade fever, typically not that 104, 105. They can have a headache, and then they have sensitivity to sound and light. And this is just a little flyer that gives you an overview of what the signs and symptoms are of meningitis. What do we do about it? For viral, we treat the symptoms. If they have a fever, we give them antipyretics. We keep the environment very low stim. And if they have herpes meningitis and they have focal seizures, we'll be giving anticonvulsants. We're going to be sending off a gram stain and cultures, and then we immediately start a cyclovir IV, and we give it at the meningitis dose. And the meningitis dose tends to be twice the dose of other viral type infections. For bacterial, if a kid comes in with meningococcemia, that is an emergency. And I'm going to show you pictures because it's one of those don't miss if this kid presents in a clinic or into an emergency room. You've got to get a physician in front of this kid. We're going to do an LP. They're going up to ICU, and we're going to immediately begin isolation. So we're going to collect all of the cultures, and they're going to start IV antibiotics as soon as all the cultures are collected. We put them on droplet precautions until 24 hours after we implement the antibiotics. And they usually like to keep it for longer than that. As long as this kid's in ICU, we don't want it to be transmitted anywhere else, so we're going to keep the kid on droplet and contact. Frequently assess for a decrease in their level of consciousness, more of the increase in cranial pressure signs, and then the onset of seizures, because this is one, bacterial tends to be a more rapid progression than a viral. We implement seizure precautions, keep this kid, no matter if it's viral or bacterial, in a quiet, dark environment. Lights are down, the TV is off. If the parents are there, we want it on very low. Limit your talking, limit the visitors, limit other noise, and once again, respond to your patient's alarms immediately. This is the situation where we're going to balance the need for analgesia for pain relief and your ability to do an accurate neuroassessment. The family is going to be totally flipped out about this because this kid was perfectly normal 1 minute and now they're in ICU and in a coma, intubated the next. They're scared to death they're going to lose their child. So everything that you're going to do, you want to be talking to the parents in a low, calm voice and explaining to them what you're doing, why you're doing, what the doctors are thinking. This child needs to be in a room close to the nurse's station. Many children who have meningitis will end up in the ICU, but remember, not all hospitals have a peds ICU, in which case this child is going to be on the floor. Meningococcal disease is caused by Neisseria meningitidis. It causes meningitis 75% of the time, and it can also lead to septicemia, which we call meningococcemia, about 20% of the time. It can cause pneumonia, it can cause joint infections, but when you look at what would you rather have, a pneumonia, joint infection, septicemia, or meningitis? A joint infection or pneumonia sounds far better than the others. When we look at the incidence, it's going to be your kids under 5, and then it's going to be your early teens all the way up to 24 years old. And this is because of the environment where they're in dormitories, when they're in the military, that type of environment, because it can spread quickly. So this occurs typically in the winter months, but I have seen it in the spring as well. The mortality rates for the meningitis is about 5%, 40% if they become septic, and then 60% if they become septic and develop shock on top of that. So this is a very serious problem. So what are the common symptoms? Fever, headache, irritable, malaise, vomiting, nuchal rigidity, rash. I'm going to show you the pictures of the rash for the meningococcal disease. Don't forget it. Then we can have the vasoconstriction, and this is a kid who has the meningitis that's now become septic, and along with that comes your tachypnea, respiratory changes, and then muscle, joint, and abdominal pain because of the septicemia. I keep saying meningococcemia, rapid progression. Ordinary flu-like symptoms 1 minute to life-threatening, debilitating disease within hours. And so this kid is going to be on renal dialysis within 4 hours. So they have a rash. It's flat, red eruption, mainly on the arms and the legs. Then you start seeing petechiae, and then we start seeing purpura, and we see meningopurpuric purple rash. These go on to develop necrosis, and we will see a distal necrosis involving their extremities, and this increases the risk that that child may lose a foot or a hand due to this illness. And this will occur in the kids who actually end up going into severe shock. So memorize this rash. This is early petechiae on the left, and then we see the meningopurpuric rash. And this is it again, all the way on the trunk. We treat meningococcemia with penicillin immediately. They're also going to be on the shock resuscitation, so when you take PALS, you're going to learn about septic shock and the different vasopressors and fluids that we need. But what we can do is we can prevent it, and we prevent it by giving them the meningococcal vaccine. So we give this to teens. What we have to worry about also with meningitis is development of Reye's syndrome. And what this is a multi-system disorder that progresses rapidly, and it can lead to damage to the liver. There's a decrease in the level of consciousness, increase in the intracranial pressure, and they have respiratory dysfunction. It is because of Reye's syndrome that we do not give aspirin to children, and you should have learned this when you studied the varicella vaccine, because part of our parent education is no aspirin. The peak of Reye's syndrome is going to be between 6 and 11 years of age, but it can occur anywhere from the 2-month-old all the way through adolescence. It follows a viral illness, and as a result of the virus, the parents give the kid aspirin to bring down the temperature to get rid of the aches and pains. And so what you need to be aware of is what products contain aspirin. Is there something that's over the counter that is more than just an aspirin, like Excedrin, Excedrin migraine, some of the other products that are on the market for arthritis? Kid goes in, helps themselves to their parents or their grandparents' medication, and it has aspirin, and they can develop this. Recognize it. You need to ask the right questions when this kid is coming in. Have they been sick? Do you think they might have taken some aspirin or any other over-the-counter cold products? We send off the ammonia levels, liver function studies, and blood sugar. We give them a D10 bolus, monitor their airway and oxygen sats. So the Surgeon General, the CDC, the American Academy of Pediatrics, and the FDA all make recommendations to not administer aspirin or aspirin-containing products to any person under the age of 19 years. And you can go ahead and go on the Rise Syndrome Foundation and you can get more information. And it gives a list of the over-the-counter products, topical and prescription, medications to avoid for children. Unfortunately, it's all in generic. And parents don't buy generic, they buy brand. This ends the presentation on meningitis.